I would like to introduce Frank Gavin, who will moderate a session on the successes, achievements, and future directions of OSSU and its distributed network of 14 research centers, that hub and spoke model of excellence across Ontario. Frank has been a very active patient partner on many SPORE initiatives, including OSSU, where he serves as our current chair of the board of directors. Frank.
Okay, thank you, Dean. And I wonder if we have some panelists. Best to come up now, Dean. So Dean is one of our panelists. Dean is going to be wearing two hats, and so I'll be introducing each of the panelists as their turn comes up. Welcome. Thank you. So. I'm going to start by talking about pronouns, because I knew that would get an enthusiastic response. But so as you see, this is not my title. Maybe I'm thinking Vasanthi may have come up with the title. I'm not sure. But the quo Tendimus. For those of us old enough to be having done Latin in school, we recognize immediately that the last three letters of Tendimus means it's a first person plural. It's we. So sometimes that's translated as where are we going? And I want to tell you sort of an alternate, maybe more appropriate translation. But I'm just thinking, that made me think a little bit about the we. Who are we in this business? You've heard a lot here, much today, about how, especially in the last panel, how we have grown in diversity, certainly among the patient partners. And in the session today, we're going to bookend it by talking about patient engagement and patient partners. Julia, who's done so much work on it, will be our last presenter today. But I just want to say something at the beginning. Yes, indeed, we have grown in diversity. So I've been involved with the Child Bright Network, and we have really made big strides in involving youth. And as we heard from Joe today, OSSU has done that as well. But one of the things we've talked about is, we wanted, as we've grown this, we want to make sure to notice who's not at the table. And that's one thing we said, who's not here? But I think we have to go beyond that and to say, is our table actually inviting to the people who are not here? Why would some not want to join the table? That would be one question. And the other question is this, sometimes there have been people who've been at the table and who've left. I know Child Bright decided to do something a while back, which was to do exit interviews for people who leave after 2 meetings, or they leave after a year, or they kind of disappear. They often, so we decided we should try to talk to those people to find out why they left. That might tell us a little bit why sometimes it's actually hard to get all the people at the table we want and to have them stay. So that's an important part of it, because this is also difficult. Now, the other question around Tendimus, yes, it can be translated as, where are we going? But it means better translation would be, what are we striving for? What are we aiming at? Because this work is, in fact, difficult. There's a real challenge in all of this. And the one thing, I'd say, looking at this today, we've heard a fair bit, I think, especially, about how much progress we've made in implementation and the uptake of our evidence. And that's really important. OSSU has had some terrific Empower Awards. It's just about putting evidence into practice and into policy. But the one thing I would say is we also have to think about upstream. This is where I think we've made somewhat less progress. And I'm talking not just about OSSU, but about the whole SPORE enterprise. What are the important things? We heard a little bit about the last panel. What are the issues? So I was thinking of this recently when I was reviewing a systematic review, doing a peer review for a big publication. And it was around combination therapies for people with Alzheimer's disease. And like a lot of people, this is something I've experienced in my own family. And it was all about, drug A and recreational therapy, or CBT and music therapy, or whatever it is. And in this entire, and it was a multinational, huge systematic review, but there wasn't a single one of the studies that had anything to do with caregivers. Not one. No caregiver intervention. Nothing there. And everyone who knows, if you live in the world of Alzheimer's or it touches you, caregivers are huge in terms of respite care for caregivers or whatever else. And in that little checkbox, there was something there about, were patients involved were they partners in this study? And the answer was no. But who would involve patients in a systematic review? But if you think about it, and Maureen would talk about, in terms of outcomes, it's really important. So in a systematic review, they have a discussion section. They have a discussion about inclusion, exclusion criteria, which studies. So if you're not involved, I thought to myself, one of the real reforms we should ask is, if you say no, sure, say no, patients were included, just say briefly why no patients were included. It might spur a little bit of thinking. So thinking about upstream is really important. So that is the end of my spiel, and you were saved any more details about that's as far as the pronouns we were to go. So just remember we. Now, for our session now, we have 5 people who are, I can say, are all terrific collaborators. They've all been part of the OSSU for a long time. One of the great things about today is to see David Henry and Michael Decter and so forth. It's like reviving some wonderful memories. So I'll introduce them in order. So Dean Ferguson. Dean, as we know, is the scientific director of OSSU, and also I think works is in clinical research at the Ottawa Hospital Research Institute. So Dean will be our first speaker, and Dean will then be followed again, I think, by Diana, and then I'll introduce each as we go along. So thank you. Dean?
Good. Thank you, Frank. I think we can go to the next slide.
It's me. I'm in charge.
Oh, are you, Joe? Thanks, John. Good. So Frank and others have spoken about the hub and spoke model of OSSU, and I think it's important because I represent the Ottawa Method Center as one of the centers of OSSU, but just like OSSU, I saw the advantage of seeding, growing, and spreading patient-oriented research within my institution, or institutions, the Ottawa Hospital and its institute. So in that vein, I'm speaking on behalf of the institute and hospital and what we've been able to achieve in the last 10 years. And obviously the Ottawa Method Center has been a large part of that, but it's not the only part. What we have achieved is getting our executive and leadership at both institutions to buy into patient engagement, as well as patient-oriented research, but certainly patient engagement. And we started by developing with our patient partners a patient engagement and patient-oriented research policy that the Institute would adopt and help champion patient-oriented research through all corners of the Institute. It started off in mostly applied research, clinical and applied research, but I'm also happy to say as a sort of bottom point that we're actually doing patient engagement in basic science, discovery, patients being involved, opening the hood to those labs and making it more patient relevant. So we did that. We followed the policy with building the strategic plan and priorities of the hospital and the institute, where patient engagement and patient-oriented research, practice-changing research, are embedded right into those policies. So those 3 things I really advocate throughout our system. So I have no worries about sustainability of patient-oriented research at a researcher level, but we need our institutions on board, and many are getting on board. As Stuart's slide earlier said, that patient engagement is embedded now within strategic plans and priorities. We then built the infrastructure. So we needed to support not just our researchers, but the next slide will show it, is also supporting our hospital management and staff in their day-to-day activities as well. So we expanded the Ottawa Method Center. We created the OPERA office, which we call the Office for Patient Engagement and Research Activities, and that's led by Dr. Nichols, and that provides all the support. So there's no excuses. That help is there, as well as the staff and scientists there to help, at both the scientific level and staff level. And this now goes beyond just the project level. So it's easy to think about patient engagement at a project level, but as been mentioned earlier, it's really important that this happens at the governance level, priority setting level, and also in our peer review. And so we've managed to start that process. We do have patients involved in our internal funding programs, both the peer review as well as a bit of priority setting, and also at the governance level, sitting on our major committees. With this investment and OSSU's investment and excellence that we can tap into the other centers, all up on stage here today, or not all, some up on stage today, we furthered our own funding success, right? Because we were ahead of the curve, that you had to engage patients, you had to engage decision makers. And so that's brought more success and influence, because the leadership, national leadership, provincial leadership on disease-oriented networks or other research initiatives led by our scientists, they then embedded research and patient engagement and patient-oriented research within their activities and networks. And I was just was at the Biocan RX, which is a large national consortium and network looking at immunotherapeutics in cancer. They held their annual meeting this week here in Toronto, and it was really, really pleased to see patient engagement and throughout the agenda. Co-presentations by patient partners. They created their own sort of knowledge institute, which trained up both researchers and patients in patient engagement. That's great to see, and I think OSSU's commitment and has certainly led to that. And then we also obviously champion and influence patient engagement, patient-oriented research beyond the OHRI throughout the province and elsewhere. Next slide, John. So where are we going? The 5 things at an institutional level, and they're shared probably at many centers across the province and elsewhere, is that continuing that drive towards a learning health system. So within the research communities, we've got some excellent skills in data science, in implementation science, evaluation, patient engagement, that we can bring to the table, the hospital's table, if you will, into everyday operations. But we need to be nimble and quick. We cannot be taking 6 months or a year to turn around a systematic review. It needs to be a rapid review within days or weeks. We do need to adopt. But all that, that work is leading us towards that learning health system, patients and data. Striving towards equity and diversity in patient engagement, we've heard a lot about that today. It's just absolutely paramount. There's a lot of work to be done. There's a lot of great work that has been done, but I dare say that needs to be our focus in the coming years. Investing in the science of patient partnership, so areas around equity, as I just mentioned, compensation, training, evaluation, all need further work itself to identify and take on those challenges, as well as determining best practices. Nurturing ECR and HQP, we spent yesterday with the ECRs. Again, we need to support them through promoting those communities of practice. And finally, sustainability. I think that's at the researcher level. I'm not worried about the institutional level. We really, really need to get there by making sure our institutions adopt and embrace patient-oriented research. Here we go. Thanks, Griffin.
Thanks, Dean. So it's my pleasure now to introduce Diana Jurajnik from the Center for Rural and Northern Health Research in Sudbury. And Diana will be telling us about the important work they're doing there. Thank you.
Thank you. It's an absolute pleasure to be here. And, you know, I was thinking about what I was going to bring here today. You know, what have we achieved in these last 10 years as the Northern Partner in OSSU? What have we experienced? What have been our successes? And where are we going? Okay, what should we be doing and what needs to be done moving forward? And the first thing that I was thinking about was my experiences. I was hired at Craner. Craner's the acronym. Somebody had mentioned earlier they don't like acronyms, or we shouldn't be using acronyms, but I'm going to use an acronym. We affectionately call it Craner. And I was hired specifically to lead our SPORE program a few years ago now. And well, I'd been at Craner, and then I had left, and then I went back to Craner. The North sucked me back in with pleasure, mind you. And I was thinking at the time, okay, SPORE and patient-oriented research, what is it? You know, how is it unique? How are we unique in the North here? And what do we bring as a SPORE center? Because Craner has always been very much applied in its work, you know, in the health system and health services and what have you, and very much engaged with people, patients, the community, local populations, regional populations, government, health and social work professionals, and I think in a meaningful way, although we can probably argue that, you know, we're always looking for better ways to do things, right? And so, and also in terms of our research and health workforce issues, you know, we have always looked to what the health needs are for our northern populations, access to care to inform and address the health services and systems that we have, and what we should be doing the same or differently, right? Also differently as well to improve health for people and populations in the region. And so back to, you know, I was thinking at the time, as an OSSU center, what are we doing differently now? What are we doing the same? And I think what happened, you know, as an OSSU center is that it gave us a critical infrastructure. It gave us a framework. And so, you know, a more defined way of going about things. Maybe a more sophisticated way, I might say, and perhaps, can I say maybe in a more coherent way? And I'm not saying anything about our prior work, but I think I'm trying to emphasize this really critical framework, you know, that has pulled us all together and it allowed us to grow, and in our thinking, in our connections, in our relationships, and with our engagements, and then of course, you know, with our research and our evaluation work in the North and also beyond. So we've been able really to leverage the OSSU infrastructure funding and supports to strengthen our existing regional and provincial relationships, and with other SPORE centers and, you know, initiatives, patients, communities, and others, and to garner more funding or other funding. This has also been really very important too, to support and expand on the work that we do. On the work that we do. And we've seen many successes. Us as a SPORE center, we started in those early days. We started with an HSFRF grant, right? And I think, you know, Vasanti, you probably remember that, and, you know, the very first collection of studies for the implementation of a collection of studies. In the area of Francophone health, on the part of Dr. Alain Gauthier, Dr. Patrick Timoney, who's with us here today in the crowd. I told him earlier I was going to single you out, and I'm doing that right now. But that first work was looking at language concordant care, or how the language spoken with the physician correlates with the satisfaction of care received by Francophone patients, which time and again it does matter. It makes a difference if a healthcare provider proactively offers services in French, known as the active offer of French language services, and which has spawned much more work if we think in terms of those important impacts, right, in the last 10 years. More work to examine the uptake of active offer, training, and are we actually implementing it in practice? And, you know, other work looking at, and also I have to say, our burgeoning training program around active offer, and around the needs of French-speaking immigrants, the distribution of French-speaking health professionals, including pharmacists, right? And, you know, when we think about our work that was done in the area of health and health services and systems, you know, looking at the practice location of family physicians and specialists by way of our connections with colleagues at Nossum University, you know, and the early tracking studies, we think back fondly to those and what those have told us in terms of the impact of physicians practicing in different locations. Does that make a difference in the North? Do they stay there, right? And would that meet the needs of the North in terms of health services and outcomes, right? So, and in the area of Indigenous health, at the inception of Craner as an OSSU Sports Center, we had the really robust implementation of an Indigenous health research program on the parts of Wayne Worry, Kristen Jacqueline, Jen Walker, focused on dementia care, reducing the burden of diabetes for First Nations, and then moving to Jen's work with ICS and data governance and the COO. And all of this laid the foundation for our further work and impacts in the area of Indigenous health, which I'll mention in a minute. And I can see I'm running out of time at this time of the day. I tend to go on and on, but anyways. Where are we headed? Maybe we can go to the next slide. I'm kind of behind a couple slides here. There's our successes. Next slide. Let's just move right to the last. Where are we headed? Where do we need to go? What's really happening here and that makes us unique is that context matters, because our successes and impacts over the last 10 years and where we're headed really have to do with context. Our work has really increased awareness around Northern geography and minority population issues, and patient and community engagement, and poorer for Northern and rural populations across Ontario and Canada and internationally. So geography makes us unique, or our sense of place in shaping our work, right? Our approach has been tailored to the region and the needs of local communities, and so our perspective diverges from other parts of the province, okay? Where do we need to go collectively? And I have a couple of things here. You know, moving forward, we have to have some really deep thinking about equity and tools for an equity-focused poor approach. You know, I would reiterate what Nav and the other panelists said earlier about equity and fairness. And just coming out of our session, our early career researcher event that we had yesterday, as one of the panelists said, equity can't be a program on the side, but embedded within our poor work. We really have to think about equity. Right? What does it mean? What does diversity mean? How do we really embed equity in our work? So our collective poor efforts need to involve a deep understanding about culture, right? Who we're engaging with, what their priorities are. We need to ask, and you know, what does that mean for us and to patients and communities, and how is that reflected in our work? So we need to dig deeper to really learn deeply about our patients and populations and communities, and understanding their priorities if we think about the Francophone and Indigenous populations that we serve in the North, okay? For example, our experiences in the area of Francophone health within our context has positioned us really to understand the realities of the many Francophones who live outside of larger urban centers, and has had a huge impact on what we're conceptualizing moving forward, right, in terms of, you know, how we measure things, how are we measuring things, how, you know, and advocating for the inclusion of French language variables within administrative data sets. With our Indigenous work, we're, you know, in building the strong foundation created by others at Craner, our work has really evolved a strong local support and evaluation capacity building based on Indigenous perspectives of wellness and models of care. So the capacity to use data that's important to Indigenous communities according to local priorities. Again, it's about local context, right? We've learned to listen, partner, be responsive and flexible. And then just in terms of the capacity building, because I can see that I am out of time, you know, it's about doing and supporting and what we're doing in terms of poor and supporting it. It takes a mindset, right? But it takes resources and investment in local personnel. Okay, patient-oriented research capacity has to be developed and maintained in the North, and it means involving the perspectives of local people who understand context. So capacity building, including with ECRs, to understand the unique needs really of Northern communities, because our needs are often different than in other areas. And I'll end with that. I did want to say a couple more words, but I'm really very much over time, and I have to give my colleagues their time here too.
Thanks, Diana. We had a wonderful OSSU meeting in Sudbury 6 or 7 years ago. It was one of our best meetings. It was a great group, so we enjoyed that. I'd now like to ask Michael Schul to talk with us. Michael is a senior scientist and the CEO of ICES, which we've heard a bit from today from Astrid Gutman about, but ICES has been a partner of OSSU from the very start. So Michael, tell us all about data and patient-oriented research.
Thanks very much, Frank. So you have heard quite a lot about ICS this morning. A number of really talented scientists and staff have presented on the work of the organization, so I won't actually need to go into too much detail about that because you've heard a lot about it. But I do just want to take a moment here to add my thanks to those of others, to you, Visante, and the rest of the OSSU team for the 10 years of support and the leadership that you've shown. I think also just Visante to point out that the vision for how OSSU would be structured and how we would work together, I think was very much yours. And I think we owe you a great debt of gratitude for that because, you know, Ontario has a lot of strengths, but collaboration is not necessarily one of them. And so you've managed to do a lot of cat herding over the last 10 years, and I think that's really to your credit and to all of our it's reflected in our success. I also want to take a minute to thank CIHR. You know, at the end of the day, this is CIHR dollars that are supporting this, and this is outside the box. I mean, not now, but it was 10 years ago for sure. And so to just underline the fact that CIHR took a big risk. There were a lot of voices that opposed this work within CIHR, within the various domains, and those have not gone away. So I think the fact that that the CIHR has sustained the support, and we hope will sustain into the future, is something that we should really underline and be thankful for. I also want to thank the Ministry of Health. I see Jillian here. The matching funds that the ministry has provided over all of these years to all of our organizations to support this is also critical. And again, this was something I think it's fair to say was new for the ministry. And again, you need ongoing support from ministers and governments to support this work. And so I think we should underline that. So just in terms of, you know, I think we're supposed to be looking back and looking forward on this panel. So looking back, I thought the best way to look back is just to sort of think about how, for ICES, how did we get to where we are now? And the slide that you have up here just kind of gives us sort of the present day, more or less, of the people that are associated, 900 scientists, staff, students, more than 120 data sets available on the population of Ontario, lots and lots of projects, lots of research output and so on. And much of this, in fact, you know, a large proportion of this work is a direct result of the support of OSSU, and we wouldn't have it if it weren't for that support. I'll give you one example. We now have a platform called Data and Analytics Services that provides access to data and analytics supports for researchers from anywhere in the country. You don't have to have any affiliation with the organization to access our data, and that was funded by OSSU. In part, and the ministry, of course, but that got launched as part of the SPORE initiative, and that was part of the vision, actually, of David Henry, who was my predecessor in this role at OSSU, and Visante, and so that's just a very tangible example. The other obvious examples are all of the work that we now do in the area of public and patient and community engagement. And we're lucky enough to have a team. Laura is here, and Sabella, another member of the team, who lead that work. Those people did not exist. Those roles did not exist when we started this work. And it started with creating a public advisory council, bringing, you know, a very traditional sort of mechanism to engage the public in our work. But we've grown beyond that as well. And you heard about that this morning. The People's Panel, the framework on race and ethnicity data, and how we are building out that work by engaging again with communities. I just want to underline one point that, you know, for us, we have data on the entire population. And that means everybody who's born, who contacts a physician or has a ER visit or whatever. Most of those people don't consider themselves patients, they're just members of the public. And so when we think of patient engagement, we think of public engagement, because we have data on anyone who basically has an OHIP card, we will have your data. And so we very much view this as public engagement. Patients are obviously part of that. But over time, we've also come to realize that you need to think in terms of communities as well. There isn't one public out there. There isn't one public out there that can be represented by a group of 10 or 15 or 20 people, no matter how diverse they are. And so you also have to go out and engage with specific communities and have targeted engagement mechanisms. And that's something that our team has built, I think, successfully. Lots more work to do. But that, again, is a reflection of the support of OSSU. Our partnerships with Indigenous groups also really critical. Those actually did predate OSSU, but they've been strengthened further by that work. I just wanted one other small point. On Maureen's panel, there was a mention about how often there's a lack of patient or public representation in governance. And I just actually tweaked to the fact that we have a member of Public Advisory Council who's now on our board of directors. And it wasn't sort of a conscious thing about, oh, we need someone from the PAC to be on our board. It was just, he was a great person. He understood the organization. He had lots of things to say. And now he's one of my bosses. And that's terrific. Okay, next slide, please. So for the next 10 years, where are we going? Well, it won't surprise you that as a Health Data Research Institute, a lot of it is about expanding the data that we can make available to researchers. And in particular, we have a very strong agenda around broadening the data. So it's not just more about health, but also about the social determinants of health, understanding how education, how receipt of social services or social supports, how interaction with child welfare systems and so on influence health outcomes. And so we're working very closely with government and regulators and partners and so on to expand the social data that we have available. At the same time as we're also trying to deepen the clinical data, so go beyond administrative data and work with electronic and digital health records at the hospital and primary care level. Another area is around new methods capacity. So as a research center, we're always trying to push the boundaries on the research that we're able to do. Part of that is about expanding our capacity in machine learning and AI research, where we're building capacity. But another area is around what we call patient contact studies, where we're using our data to identify individuals that appear to be at risk of an adverse outcome and contacting them to invite them to participate in a trial. And this is a new way to use population-level data. It's something that hasn't been done before in Ontario. It hasn't been done in very many places in the world, in fact. And if we can succeed at that, I think it's a really exciting opportunity for Ontario. I know I'm out of time, but I'll just say a couple more things. Clearly, we want to be expanding the engagement, our efforts at engaging with the public, with communities, with targeted and specific engagement mechanisms, as well as our engagement with our First Nation, Métis, and Inuit partners. We want to also build on our ability to enable access to data and analytics to those organizations, to communities, to members of the public. And you heard a little bit about that this morning. That is an area that we want to continue to see grow. And if I just finish with two thoughts. One is that I think, in a sense, we all sort of feel that if we keep at it, this is inexorable. We're just going to keep getting better and better, that this is inevitable. And I don't think we should take anything for granted. I think if you look at what's happened in the US in just the space of a few months, how the entire agenda around health equity, around EDI, no matter how you want to define that, has been reversed in the space of a couple of months. Don't for a second think that we are immune from that. We don't have some special Canadian immunity to that. And even if it's more subtle than what's going on in the US, even if it's not quite as dramatic, there's nothing inevitable about this work. And so we have to keep pushing at it. And finally, I think one of the things that we need to all be thinking about is how do we ensure that as we talk about health equity, as we talk about expanding this work around equity and inclusiveness and so on, how do we ensure it's not seen by some as a zero-sum game? That if somebody else wins, I lose. How do we ensure that we're pitching this work, we're demonstrating that this work actually is lifting all boats, that everybody is benefiting from this? I don't have the answers to these questions, but I think they're things that we need to think about as we work to advance this work.
Thanks, Michael. Michael's last comment reminded me of a really terrific book called The Spirit Level, which was done by two epidemiologists from England, I think, talking about how greater equity benefits everyone. So it was a really wonderful book that's 10 years old, or 15 years old, but still great. Now, one peculiar, our last two speakers have something in common. They are both from McMaster, Hamilton. We try for diversity here on the panel, but McMaster has been doing so much good work being done there. So, and I don't think OSSU has ever met in Hamilton, which is our big weakness so far. But almost every. There's some there, but anyway, but we're delighted to have two speakers from McMaster and Hamilton. John Lavis, when I think of John Lavis as the professor in the Department of Health Evidence, I think of John in terms of evidence, impact, and I also think of the work John's done in the McMaster Health Forum as well. So John, please tell us about your work.
Thank you very much, and you're welcome in the Hammer anytime. I'm going to zero in on achievements with one of our 4 pillars, the Learning Health System pillar. And a lot of accolades today have appropriately gone to Vasanthi. I want to single out 2 people who've been game changers with this particular pillar. Rob Reed came back to Canada, such a great bridge builder. And Michael's point before about this is not a province where collaboration happens naturally, and he has worked really actively to bridge across these different communities. And I also want to single out Maureen, who, before there was the comment about whether you can involve citizen partners in evidence syntheses, during COVID, Maureen brought together a group of 20 citizens. They would jump onto rapid reviews, work in 5 days through the night to give guidance to teams. She's now set up a new group of 20 citizen partners to do the same thing, but she's also changing our thinking about learning health systems. And when I think about how we're going to make a difference in future, I think we're going to do it using a collective impact approach. And I want to talk about a couple of ways that we're making incremental progress in that direction. So Rob and team built a learning health system action framework and brought a lot of people on board, and that is starting to change how we work. Then the ministry and Ontario Health are becoming increasingly clear about the system-wide priorities that we need to be focused on, like primary care access and attachment, the I-12 OHT acceleration priorities. That helps us know what we need to focus on with our collective efforts. When you come to the mutually reinforcing activities, just within RISE, we have Brianne Wood, particularly good on the population analytics, Gear 1. We have our team particularly good on the timely, demand-driven evidence synthesis and support. We have Kaylin here who leads that work. We have Rob, who's particularly good on the implementation gear, but also those conceptual and experiential contributions to what a learning health system needs to look like on the ground. And then we have our RISE coaches trying to help teams to move those gears over time. We have some communications that happen. Some of you know we have an Ontario Learning Health System working group that meets periodically. We just opened our last meeting to partners from around the province, really inspiring to see all the activity. A couple of years ago when we asked who was doing learning health systems work, you'd hear crickets. Now all kinds of activity. Now some of it I wouldn't necessarily say is full-blown learning health systems. Setting up a data analytics dashboard, in my view, isn't a learning health system, but it's a step towards it. And now we have these centripetal forces. 10 years of OSSU being a centripetal force in a research system in this province that is prone to dispersal. And we have RABE, the Research Analytics and Evaluation Branch, led by Jillian, another really powerful centripetal force in the system. And then when we come to learning health systems themselves, built around learning and improvement cycles, in addition to the fantastic patient-oriented research that you do, often on timelines of years, we also increasingly now have timely demand-driven evidence support that can respond in days and weeks and months. Days with ultra-rapid syntheses that Maureen and other citizen partners are in, but we're also seeing people now do rapid forms of new primary research in weeks and months instead of years. And the partnerships to support those cycles. We're now seeing a world where no longer do we see researchers working in isolation. We're seeing that three-legged stool. So Bing, I owe you $1, Maureen, already. Researchers, patient partners, and system operators working together. And today we had a couple of two of those. Like the mental health panel was system operators and researchers, but no citizen partners. Other times we had citizen partners and researchers, but no system operators. How do we get to a world where we always have the three-legged stool? So a lot of achievements. Thank you to Maureen. Thank you to Rob. 3 opportunities ahead, and I'm going to go in reverse order. I'm going to start at the bottom. in my world and Maureen's world, which I call evidence world, massive changes happening globally, really exciting stuff. Canadian federal, provincial, territorial governments, with only a few exceptions, are largely absent in shaping those conversations and preparing Canada to respond. Other countries are out there, not the US, but many other countries are out there shaping those opportunities and thinking about how they prepare their research systems. So let's put pressure on those governments to start to engage in those global developments. They will mean 1 cent, 10 cent dollars for us if we engage in them. Second thing that I would love to see is broader coverage of all relevant forms of evidence in our timely, demand-driven evidence support system here in Ontario. It was striking to me again today, data analytics, data analytics, data analytics, really big focus in this province, but it's one form of evidence. We are starting to see much more rigorous evaluation. We're starting to see behavioral and implementation research really take off. Justin was sitting here before. But modeling, qualitative insights, evidence synthesis, guidance have a long way to go to have seats at most of the tables. You don't answer a policy and a program question with one form of evidence. You need many to understand problems, to understand solutions, to understand implementation, and to monitor and to evaluate. And the final thing, the thing that I'm most excited about and would love to work with Jillian and many other people on, how do we build more general contractors in this province? All of us who are trained in research, typically we have 1 or 2 trades. And if I'm trained to use a hammer, everything I see is a nail. But that's not the way that it works for most of the system operators out there and most of our citizen partners. Sometimes they need qualitative insights, other times they need BSI, other times they need data analytics, and you need a really good general contractor to get the right trade in at the right time. And to me, RABE is uniquely well positioned to be that general contractor. So thank you to Visanthi, but also thank you to Maureen and Rob for the leadership that we've seen in the learning health system space. Thanks.
Thank you, John. Our second person from Hamilton, the person from Porlock, anyway, is Julia Abelson. Julia is the lead of the Public and Patient Engagement Collaborative there. I also one thing that I've come to appreciate with Julia is she is very dedicated to helping young researchers, people in graduate school. So I've been involved a little bit, and I know how encouraging and helpful. It makes me wish that I were a graduate student today rather than a million years ago when supervisors were behind locked doors, it seemed, and resented being sent a note. Anyway, that's water under the bridge.
It's never too late.
Too late. I know, I'm too late. But anyway, so also Julia is the main developer of the PEAT. An evaluation of patient engagement is very important, and Julia has been extremely helpful in a very pragmatic way in developing some tools. So Julia?
Great. Thanks very much, Frank. I guess so. I'm the other bookend, and I'm going to bring us back to patient engagement and partnership and the poor enterprise. But I guess in some ways I feel like my job is really easy because we've had so many excellent reflections and insights on patient engagement and partnership. I mean, particularly the session that preceded this one. So I think I'm going to be doing more sort of reinforcing of key points and maybe a little bit of my own take on things as someone who's been in the field for quite some time, well before the 10 years of OSSU, really. I guess I'm celebrating my own sort of quarter century anniversary, 25 years, right? Working in public engagement and now patient, and then all of those things in between and beyond. So really pleased to be able to offer some reflection. So if we can go to the next slide, John, thanks. So I'm going to just bring us back 10 years ago to some of, those of you who weren't in a room like this and not working in this space. So we had this call, maybe easy to do, maybe not so easy to do. In fact, Michael's point being a good one about CIHR, it was a big deal for SPORE to be announced, created, initiated, launched. And then it was not so easy to do, right? Not so easy to implement this, figure out. And lots of, feelings of challenges to the status quo, right? You talked about that, Michael. Many people embracing it because, frankly, some groups were already working this way and just were really pleased to see the increased investments in this to do more. Others were looking to get into this kind of work for the first time, but many skeptics, many people really threatened by this in really big ways and trying to derail it, frankly. And I think underlying that was, some fear, right? And frankly, uncertainty about how to do this. What does this mean for me? I don't get to do the research in the usual way. What does this look like? So lots of change since then. Next slide, please. So we've come a long, long way since then, right? And you've heard many people talk about that already today. I would make 4 key points on this topic of notable achievements. In particular, the value of working this way being more widely recognized and accepted. I don't think we can really overstate that. It has been commented on, in particular, the patient partnership session. You have seen this very much in your own work. We're not there yet, absolutely not. I see it, quite routinely. This nice to have, but we don't, really, it's sort of a frill, frankly. But I think many people really, really seeing the value of this, and as the research presentations that we've had today and reflections earlier in the day, showing how tremendously valuable that working this way is. I would say also, for me in particular, someone who kind of brings a lot of the conceptual underpinnings and theories of participation to the mix, seeing more sophistication and maturity in our understanding of the P and the E in patient engagement. And frankly, we're way beyond PE, right? As Michael, many others have talked about, it's community engagement, it's public, it's citizen, it's variety of people with lived experience. So we are so much more sophisticated in our understanding of this world and how to do this. We also have a tremendously rich supply of resources and guidance for how to do this well. I think it was Sandra in the previous session who said, let's not do any more research on how to do this. We know how to do this. I think our problems or our challenges are in the implementation side, and I think we will be seeing more of that coming over the next few years, and some work that I'm really interested in doing in that space too. And of course the impacts, we're seeing sort of the fruits of our labor now coming. We do have some good tools. Yes, I've developed some, but there are others, other folks who are developing excellent tools. So we're really starting to see beyond just, is this good? Do people feel comfortable? Are we bringing the right people together in the right room? But the impacts, right? And again, remembering to, I would say, the previous panel in particular, that's, after all, why patients are getting involved in this, to see impact. And I actually think we really need to do better, and we are seeing some rigor being brought to this, but I think we will be seeing more of that over time. So initial notable achievements, but lots more work to be done. So if we go to the next slide, I'm now going to do a little sort of interlude before I get to future directions, is the persistent challenges, because we have a number of them. The relational nature of the work, right? Again, been talked about by previous speakers. Relationships are key to engagement and partnership. In fact, to any partnership work, whether it's with patients or with others, it often gets crowded out very quickly by other things, right? It's tough to do, and yet it needs to be given the proper time and attention. I also think this idea of the kind of the democratic goals or ideals for all of this work, the democratization of health research, of science, of policy making, of decision making, bringing more accountability and responsiveness to this, I think that sometimes gets lost in our kind of enthusiasm for the micromanaging of how do we exactly do this engagement, and maybe sometimes the risk management aspects of it. So I think we just need to find a little bit more balance there. On the evidence theme topic and learning health systems, learning and improvement, obviously absolutely essential to all of this, but I think in the engagement and partnership space, we also need to make sure we complement that with just understanding good guiding principles and even the ethics of doing good work in this space. I don't think we always need the evidence to support. It's the what does it mean to not be harmful in our engagement and partnership practices, and what is reciprocity and actually building good relationships. I think we actually know a lot about how to do that in that sort of ethics-oriented way. And lastly, I just this point about how to build this into the everyday work of health systems with so many competing priorities. The SPOR Refresh document, I think, handled that nicely in saying this is a huge challenge and we need to be paying attention to this. And again, some implementation work that I'm starting in this space, I'm quite excited about, and many others doing work, is how do we actually make this the everyday working way of doing things. So I'll end with some, I guess, more calls to action rather than future directions. As you sent your slides in and then you have a different take on what you want to say. So for me, this is calls to action. And again, I would say almost all, if not really all of them, have been talked about. The opportunity for leadership in addressing inequity. So We heard that emphasized tremendously well in the equity panel this morning. And I would say in these very turbulent times, this is the opportunity. So I think it was chaos can, be an opportunity, and this is absolutely where we are. I think recognizing the political nature of partnerships, I think the Graham Crawford from Ontario Health talked about the importance of political evidence and knowing kind of where you are in the political landscape. I think that's key. We need to be more sophisticated. We need to work smarter on this and get it. There will always be people who want to advocate and have power and maybe even portray themselves as being advocating on behalf of others. There are always going to be those who do not have voice, do not have power, or whose power needs to be supported and brought to another level. I think that's hugely important. And I'll end with the last 2 points, one of which being this idea of interdisciplinarity, and I think it was Astrid Gutman who actually talked about it in her presentation this morning. The more of that, the better. That's where I've seen teams be incredibly innovative, right? The catalyzing of innovation is when we actually cut across those disciplinary boundaries, those comfortable ways of doing things. And lastly, I would say, and this is where I think I'm going to reinforce Joe's presentation from this morning about actually having as we develop that deeper understanding of the different approaches for engagement and partnership, whether that's co-design, or I think she talked about the lighter touch points. Not everybody wants to be co-designing or even on the governance table. Some of them want to just do things in their own way, for their own purposes, in the way that they have capacity to. So I think we need to embrace that. I think if we do that well, strategically, creatively, I think we've got an incredible recipe for great things to come in the future and around health system change and improved population health outcomes. So I will end there.
Thank you, Julia, and to all of our panelists. We have a number of questions. So what I'd like to do is I'll ask the question, and I'd like to get to as many questions as we can. So maybe brief answers, pointed answers even. So the first one's very provocative. In a post-truth era, and with eyes on politics to our south, how do we grow from engaging a few patients to engaging communities?
Well, I'll start by saying we actually heard some of that this morning, right? We actually had I was incredibly impressed. I mean, not surprised, but just really impressive, thoughtful ways of understanding communities and communities who need to be brought into research, but not brought in that, we talked about this is, our table. My table is not interesting to people who I think are important to connect with. So it's being a lot more creative, going to community leaders, actually having community leaders themselves, ambassadors. I mean, there are many, many models out there, and frankly, that's the community-based participatory research realm that could be tremendously helpful to contribute to patient-oriented research.
Michael?
I think also, we need to rethink the ways that we disseminate information as researchers and as a research community. It was mentioned this morning that some of the studies that even patients participate in are behind paywalls and so on. But even if they were free access, most of the members of the public are not reading scientific papers. And so I think we need to think differently about how we disseminate information, how we build trust with the public, if we're going to be trusted, because currently I think for many parts of our communities we're not trusted. We may think we should be because we're all good people and so on, but we're not. Whether you're a university or a teaching hospital or research institute, there's not an automatic trust. So figuring out new ways of engaging, I think figuring out new ways of communicating is going to be critical, and I don't think it's easy because the incentive structures aren't there. We are rewarded for publishing in the traditional way. That's how you get grants. That's how you're demonstrated to be successful. We're not really currently rewarded for these kinds of new forms of communication, which I think are going to be critical to reestablish that trust.
Just something Michael there said reminded me, Antoine Boivin, who's worked closely here, was at one of our first OSSU meetings. He and I were on a panel together at CIHR, and we were looking at patient-oriented research grant proposals that required a lay summary. And Antoine put the lay summary through one of those things that indicates what the reading level is. And Antoine found that the lay summaries were written at the reading level of grade 16, i.e. university graduate. It speaks for itself. Now, Next question. This is for you, Michael. The need for data support at the pace of policy. How is this driving change at ICES?
Yeah, that's a great question. Actually, before I kind of answer the question, I just want to underline the point that John made about data being one form of evidence and not the only form of evidence. And often, I think Graham also this morning talked about how if you don't have the data you need, just use some other data, another indicator, and you pretend that it's sufficient. Often, the data is actually the easiest evidence to get, and therefore that's all that you do. And I think that's not sufficient. It never has been, but it increasingly is not. Now we have the additional problem that even the data we have is often not complete enough or not timely enough. So I think the ways that we have been working on that really are with our data partners. So we typically receive data from multiple data partners, and we work with all of them to try to ensure that we're getting that data as quickly as possible, that we're able to process it as quickly as possible and make it available. An example of how we're doing that is, for example, now working with, some of you will know, the Gemini Initiative, Fahad Razak and Amal Verma, who are bringing in electronic health record data from hospitals, so much deeper clinical data. And so that is coming, it's not real time by any means, but is certainly more timely than administrative data in many cases. And so, I guess there's no sort of simple answer to that, but rather to say it is definitely an issue that we are trying through as many avenues as we can to address. I think also, though, that it's important to point out that, if you're thinking about issues around health equity and access, you don't necessarily need real-time data to identify those issues and also evaluate policy initiatives for success or failure to address them. So I think there's a lot that still can be done, even when your data is not entirely real-time.
Okay. I think, John, this next question is, you can take the first stab at it, and it is this. Beyond the "it's the right thing to do" argument, what would you point to as the value or impact created through patient-oriented research in Ontario to convince people to maintain investments and momentum? So impact.
What's the justification for it?
Yes. What would you point to?
Yeah.
What kind of evidence? Evidence of impact, I think.
The patient-engaged research, this is much more Julia's space. Okay. I would just say that it feels to me like there's a virtuous cycle of, if you're working in a potentially high-impact space, you are likely going to be doing much more exciting research that ends up in more prominent places. It's not always the case, but I think there is. It feels to me like I do my best work when I'm faced with a real system challenge and have to work with partners to kind of noodle through it. So the more that I put myself in impact-oriented environments, the more likely I'm going to do good work that will then have other benefits down the line. But I think Julie's much better positioned than me to talk about the impacts of the patient-engaged research.
Well, if I understand the question, one answer could be, and I'm thinking about domains of impact that are built into our Engage with Impact toolkit, which followed on the PEAT, the Public and Patient Engagement Evaluation tool you talked about, Frank. Equity is being one example. If the whole idea of equitable engagement is not for that as an end, it's to actually engage in diverse ways, in inclusive ways, in equity-oriented ways, so that our programs and services are more equitable. Right? So to me, if you're actually a patient-oriented research initiative that does that good work of equitable engagement, an impact that we would hope to see out of that would be more equitable. It would start with the research, but then the research moving into the health system, right? And we'd ultimately see more equitable services and programs, right, that respond to the needs of those populations who were actually fully engaged in the research enterprise itself.
Okay.
Does that make sense?
It does. I know someone raised the question of, should we regard patient-oriented research as itself, especially when it's done with communities, as an intervention? Does collaborating with particular communities in itself represent, an intervention? that you might compare to some a kind of clinical intervention in some ways? I mean, does it change things? Does it change things within that community? And now, I have heard people say they have witnessed this.
Go ahead.
I might see it different. Might flip that around. I think that the intervention is actually on the researchers. I think if a group of researchers goes out and engages a community, the likelihood of that community being changed meaningfully just by that interaction is not that high. But the likelihood of the researchers being changed and the research question being changed and the research approach being changed is much higher. So in a sense, I think it's kind of maybe a reverse intervention on the researchers, which is, I think, a very
Right,
positive one,
right,
typically.
Right.
But you also, if I could counter that a little bit, I mean, I do agree, but I think and again, it's more the individual, not so much community, because to me, that's a larger
Right.
entity. And so I don't know how we involve members of communities in patient-oriented research. They could have a very transformative experiences that they might take into other activities that they're engaged in, right?
Right.
As leaders in their communities. So I think that can be a way of thinking about it.
Right. Okay.
And especially if it, if it meets the priorities of what the community has,
Yeah. I mean, it would be interesting to hear from people from indigenous communities who've had experience, but I won't dream of speaking for that, but I know sometimes I've heard in the past people from those communities, when something has been beneficial, speak positively about a particular intervention. Okay, the next question. What venues exist for spore support units to learn from one another? So I guess this means support units from across the country. Right. So Vasanthi, maybe.
I
Yep.
just wanted to say we have all jurisdictions participate in monthly meetings as a council, but we also have communities of practice that have been struck through those councils. So there's multi-layer engagement.
Right.
Between, we don't have, the Maritimes are one, so we have 11
Right.
jurisdictions in
Right.
sport. But we're all connected, and more importantly, we're always connected to CIHR. Amy's team is part of this work, so we're in constant communication.
Yeah.
With several layers of working groups, like communications is one, capacity building is another, patient partnership
Right.
is a third.
Yeah.
So, yes, they're well connected.
Right.
And have been from the start.
Right. And some are much newer than others, so there's a lot of sharing.
The new ones seek for support and get it
Right.
from the old ones like us.
Okay. Yes. Sure.
I mentioned the Learning Health System Ontario Working Group, and then to Vasanthi's point, there's a national community of practice. And it is good to have a sense, and I see one of our partners from British Columbia who's here, who's part of that national initiative. And it is good to kind of every once in a while check in with people. What I think would be even more transformative is if we work together on shared challenges. And so back to the general contractor idea, if there's a way in which, with this big push on primary care access and attachment, we can have much more active collaboration on who's answering which pieces of the policy and program puzzle, and then shift over time what we're doing to respond to one another and try to figure out how do you make the whole greater than the sum of the parts. So I think there are opportunities to learn, but just like we tell the system operators, there's nothing like learning in the context of an applied challenge. We all have an opportunity to play a role in improving primary care access and attachment in Ontario now. How does Michael leverage ICES and their assets? How does Craner leverage its? How do we leverage ours to collectively answer the many, many questions that need to be answered if we're going to put a big dent in solving that issue?
Frank, can I just add?
Sure.
Oh, sorry. Dan.
Sure.
Oh, no, go ahead. I was just going to agree with you, John. I mean, I think, if I think back, if we can ask ourselves, what would we have done differently? Or if we knew today what we, knew back then what we knew today, I think a huge thing would be leveraging our collective, and that's all I wanted to say. Over to you.
I was just going to say that in addition to the cross-links across SPORE support units, there are also SPORE, other CIHR-funded SPORE initiatives that are national, and the one that we're involved in is called Health Data Research Network Canada, which brings together essentially all of the similar shops to ours in other provinces, in territories, and CIHI as well, StatCan to a degree, all in an effort to work more cohesively across provinces, enable pan-Canadian research, learn from each other, and essentially, again, raise all boats. And in fact, some jurisdictions like PEI and Saskatchewan really didn't have any data infrastructure, and that has now been launched as part of that initiative.
Dean?
Yeah, just to say in the OSSU 2.0 over the last 5 years, that was part of our mandate from CHRs. 50% of the funding had to be spent between the SPORE entities, both SPORE support units and the sort of networks or disease-oriented networks.
Yes, John.
I just wanted to add, because we've been hugely inspired by it's HDR in Canada, right? The kind of hub and spoke model for data analytics, and we desperately need it for all the forms of evidence. So we've been talking with Justin Prisseau, who's no longer here, but a hub and spoke model specific to behavioral and implementation research. Talking to Stephanie Montesanti, a hub and spoke model specific to qualitative insights. We need to have these groups organized by form of evidence so that they can help one another out. And if a B-side question comes in to Justin, but he's not the right person, he can turn to Simon Bacon at Concordia to do it. And if Stephanie gets a question about qualitative insight, she can turn to another group. So we need HDRNs for all of the other forms of evidence. And that, to me, is what a next generation SPORE could help to bring about.
Okay, I just wanted to, another question came in, and I'm going to just revise it a little bit to ask a question I've often heard. Initially, there was an idea that patient-oriented research would get into practice quicker, more quickly, because users would be involved, all kinds of policymakers would be involved, early engagement, et cetera. And people would see its utility, its practicality, its importance. But the question is around time. On the other hand, some people think patient-oriented research, at least in some aspects, can take more time. We've learned about how relationship-rich this is and how it gets sometimes complicated by relationships. And it's certainly my experience, you bring on board people, and let's say there was an initial research question, or something was identified as the primary outcome and something else was the secondary outcome. You bring on patients who say, wait a second, I think that secondary outcome should really be the primary outcome. Or we want to add some outcomes, or we want to change the inclusion criteria. I heard we had one in Child Bright where there was one looking at a study looking at metformin for children with cerebral palsy, and we had some parents say, we can actually crush those pills. We can actually include children who consume the metformin in a different way. So you got to change your inclusion criteria because there's a whole bunch of children who are being excluded unnecessarily. So that changes, and of course it might change what happens at an REB. So can you address the question of time and patient-oriented research? Do delays, are they justified? Are they to be expected? Have we learned something that can expedite the process?
I feel like Maureen and her pool of citizen partners have shown for the type of work that we do, they are not the rate limiting factor. So, if you tell them you have 3 business days, they will deliver what they need to deliver in 3. If you tell them you have 3.5 weeks, they will deliver what you need to have in 3.5 weeks. So it doesn't feel, in the type of work we do, it adds huge value and doesn't slow you down. But I also just want to add a point that was raised indirectly by the question, which is that I don't think we should be expecting our single research studies to have impacts. If you're trying to have an impact on policy, you need to convince people there's a compelling problem and we understand what's driving it. You need to convince them there's a viable solution. You need to convince them you have an implementation plan. You need to talk to them about why the politics at this time might be conducive to action. Any one study is just a little piece of that bigger puzzle. So if we turn it around, if you're looking for impact, where Maureen's spending her time is much more likely to have an impact because the question has come from the system. You've been given a couple of business days and the window of opportunity is now open, and if you deliver high value content, it has a good chance of being developed. So we don't want every study to have impact, but we want it to be done in a way that adds value for the day when the window of opportunity comes open. So I'm a believer that you need many, many studies on many different types of questions to robustly answer questions, and we shouldn't set our expectations too high at the study level.
Yeah. But the only thing I think, I'm just thinking about maybe because of my experience in child health, if you're asking parents, say, to bring their kids for a sequence of MRIs and a series of studies, in there's an expectation that if there are findings that seem helpful, my child or children like my child will benefit before I'm a senior. I mean, there's a real. I mean, I think that it's just just as a thought, anyway.
I guess I can't help myself. I just back to is it worth it to take the time? Like the scenarios that you actually outlined, Frank, yes, because if it's a more meaningful outcome measure that came from the people who are actually going to benefit from the research, like, yes. And I don't think it's, and again, I can't speak to every single patient-oriented research study and understand what that time delay is all about, how long it is, but can't that be better? Must not that be better than carrying out a very efficient, nicely done research study that actually isn't a good piece of work? Yeah. I think that's obvious, but I don't know.
Yeah.
So I couldn't help myself, but add to that.
And I can't help myself either because I completely agree with you. And especially when it comes to, the work that we do with Indigenous communities, right? I mean, is the time worth it? Absolutely. I mean, that's the way of going about it for community, right? And there's can only be benefits in the end. We're meeting the priorities. We're having or letting the self-determination shine through here, which we really should be. It's critical. So, I agree with you, Julia.
And I would just, I was going to add that I think it goes back to the question earlier of trust in this age of misinformation, that if you actually want your study to be believed and have an impact and change behavior or whatever within a community or at an individual level, there has to be trust, and the only way you're going to build that trust is if you take the time to engage throughout your process. So, it's again, as John said, it's not just one study. It's a whole way of working, I think, that has to evolve, and I do think that the benefits far outweigh any delays or added complications.
Right.
Which, by the way, I think are often overstated. It's just because you haven't done it before.
Yeah. Dean?
Yeah, and that upfront investment in my world of clinical trials pays dividends because you have more relevant questions you're answering, and that affects, patient recruitment and retention, which I think there is greater efficiency there. People will take part in the more relevant, patient-relevant trials.
Absolutely. And it reminds me of something that you said yourself yesterday, Frank. You went to Jen Walker with 10 studies, and you loved those 10 studies. And you said, okay, what study do you want to do, for community? And she said, no, like we can't. No, it has to be according to the priorities, and it's what the community wants, and it's a value to them. So, and here, that speaks to, paying dividends in the end, the priorities of patients and communities.
Okay, thanks. Yeah, it's a relationship-rich environment, I think. And,
absolutely.
you know, it was 11 years ago at our first showcase event. You know, I was recalling how, you know, our own experience with research. We enrolled our son in a study, took him out of school three whole mornings, took time off from work, brought him into CAMH where the study was being conducted. You know, CAMH to an 11-year-old, you know, he said to me, "Dad, I'm fine the way I am," which was the most painful thing I've ever heard. And the point was, you know, in there's an expectation that something will come of that. You know, something you'll get, you know, you'll get more than a perfunctory 3-sentence thank you note. So anyway, sorry for doing all that. So I want to thank all the panel and for their wonderful contributions.